present, I would say that autologous transplant is still the standard of care for patients younger than 65. There is one study that already finished the recruitment, and we are waiting to more mature data before having the last word. At present, the study is ongoing. The results are not final, so I would like to wait for final results before changing the old route that has been until now a good route.
Okay. For those younger patients, there are candidates for consolidation therapy with autologous bone marrow transplant. Are you aware of an established phase 3-based data that indicates a superiority of any combination therapy for a pre-transplant induction over another? Is there a priority in these?
What is coming is not also from this point of view there is a real answer to give. The general impression is that an induction including a free drug combination might be a little bit superior to a two-drug combination. The impression is that a Velcade-based induction followed by autologous transplantation followed by maintenance with lenalidomide could be considered today one of the best possible treatment available. We do not know yet which is the best combination for induction. We are thinking about free drug versus two because the free drug gave a higher response rate in comparison to the two drug. And we do not know yet if it's really need a consolidation after autologous transplant.
By the way, which drugs you referring for the three drugs?
Sorry?
What drug?
That's the issue because generally speaking, corticosteroid is always present. The third drug could be cyclophosphamide or doxorubicin from one side, lenalidomide or thalidomide from the other side. So the third drug is usually an IMiD, lenalidomide or thalidomide, or cyclophosphamide or doxorubicin. Can I give probably a little bit different answer? What I would suggest is to go to a center with a lot of experience and to some extent talk with the doctor and define with him the right path. Generally speaking, what is very important is this is a rare disease. So if a physician has one case per year, he has a limited experience. If he has 100 cases per year, he has a different experience. So if I can usually give a suggestion, my suggestion is try to find a center, a place where they treat this disease with frequency. This should be the choice number one. And at that point, I would follow. I'm not even that much a fan of second opinion. Because to some extent, the second opinion should be, to some extent, again, done by another very experienced center. And the second issue is, before you really know a case, you know all the detail, you know all the specific condition. It takes time. It's not always easy to do it in 1 hour. And from this point of view, sometimes the second opinion could be also. But my suggestion is follow an experienced center and trust him.
The next question is regarding another thing at all. because there is a big confusion that I hear about lately regarding the issue of maintenance, or what you call in post-induction therapy. The French group recently reported data that post-induction lenalidomide that is different than the Bureau group have found. And they are indicating therapy even for patients that did achieve a very good response by the induction therapy. What do you suggest for patients that are not treated in an experimental setup, like in our cases? We don't have experimental, unfortunately, you know. In this,
no, you have some.
We had, but we are not in this case now.
You see, lenalidomide maintenance, I think, is now showing enough strong data to be incorporated with probably some more longer follow-up is needed. Mm-hmm. Let's say this. I think there are now enough strong data to suggest that lenalidomide as maintenance should be incorporated in the treatment of myeloma. I would like to wait probably other few months, 1 year, again to have enough follow-up to say the last definite word. I would say here we probably have 70% of the evidence. Mm-hmm. Let's wait a little bit longer to confirm. If those evidence will be confirmed, I think lenalidomide should be included in the treatment. Everyone, and to some extent, there is a philosophy, and I will spend a word on this. The philosophy says, if you reach a VGPR, a very good partial response, don't do a second transplant. If you reach a very good partial response, don't do consolidation maintenance. I think this is a mistake, because it's been already shown that specifically in patients with very good response, and therefore with a very sensitive disease, and therefore with a very good prognosis, that you can really take out the best from those drugs. It's much more difficult to improve outcome in a resistant disease. It's much more easy in a sensitive disease. So if someone has a very good response, means it has a very good sensitive disease. And from this point of view, I do not like the idea of saying, well, since you have a VGPR, don't do anything else. This is a mistake. So certainly I'm in favor of treating all subgroups, and I'm not in favor of saying stop here and keep going there. What we don't know is how long should be the length of treatment with lenalidomide or thalidomide, and from this point of view we do not have study. Is 12 months good enough? Should we go until progression? This is until unknown. The evidence at present are until progression, and from this point of view, this should be the rule.